because I think we are going little beyond schedule. So that's the reason the organizers has told us. So I'm sorry we'll not have your discussion now, but after completion of the other three. So next we have my co-chair, Dr. Shradha, I think. Yes. Yeah, and she practices abundantly spine, and we have her to present today on spinal cord malformations. So over to you, Shraddha, and she's practices in Mumbai, and she is also doing some workshops abroad. That's what I know of her on teaching spinal cord I mean spinal instrumentation surgeries in our nearby countries. So over to you, Shraddha, for your talk.
Thank you, ma'am. Saurabh, can we have the recording? Saurabh?
Good afternoon, everyone. Today I will be giving an overview of spinal cord malformations. As we all know, neural tube defects of spinal cord are a spectrum of congenital anomalies that include open and closed spinal dysraphisms. Open dysraphisms or spina bifida aperta are seen physically during the birth of the child and include malformations like myelomeningocele. Closed spinal dysraphisms or spina bifida occulta are non-visible skin-covered lesions. The etiology is often multifactorial, consisting of environmental, maternal, and genetic factors. Maternal factors are most important, including irregular nutrition, low folic acid intake, use of certain anticonvulsants, and maternal diseases like diabetes, obesity, etc. Approximately 140,000 cases of neural tube defects are born globally per year. The incidence of spina bifida is 0.5% in 1,000 live births, and the recurrence rate of myelomeningocele with consecutive pregnancies is 2 to 3%. A higher incidence has been reported in females which have increased maternal age and lower socioeconomic status. The pathophysiology of spinal dysraphism is during the development of spinal cord and its elements in embryogenesis, which is second to sixth week of gestation. This development occurs in three stages, which are gastrulation, primary and secondary neurulation, and it is the defects in primary neurulation that result in open and closed spinal dysraphism. The clinical presentation is dependent on the site of spinal lesions in the vertebral column in these patients. The higher the affected level, the more neurological deficits occur and worse is the prognosis. However, in our experience, patients with high cervical and thoracic and high thoracic region malformations generally do not show much neurological deficits. It is the lower thoracic and lumbosacral myelomeningocele which have worst prognosis. Symptoms like neurogenic bladder, lifelong functional disability, and problems like paraplegia, sphincter dysfunction, motor and sensory impairment, which worsen over the age, are other associated clinical presentations. These problems often are not alone, and associated problems like Chiari malformation is most commonly seen in these patients. Other problems of this vertebral column itself, like tethered cord, vertebral body, or bony anomalies, diastometamylia. In the brain, hydrocephalus, corpus callosal agenesis, anencephaly are some of the associated features. Even other organs in these children can be compromised and may lead to different problems. The evaluation of spinal cord malformation consists of three main tests, which are amniocentesis, ultrasonography, and an MRI. Ultrasonography is the gold standard and is a safe, non-invasive, effective method for anomaly scanning. The treatment, of course, now consists of a prenatal option for these patients. The MOM study, which was done in United States on 60 pregnant ladies between 2011 and 17, wherein an in utero repair of myelomeningocele was performed, showed that the fetal surgical repair was more effective than postnatal surgery in preserving neurological functions, as well as reducing the need for reversal of hindbrain herniation and shunting. However, it came with a set of complication during the delivery, which was uterine rupture. Consequently, they suggested that the delivery of such children should take place via cesarean section at early term or late preterm. Postnatal surgeries, of course, are most commonly performed in developing countries like ours, usually done within the first 24 to 48 hours to prevent risk of infection. Small lesions require primary repair. However, larger lesions with inadequate skin closure may require a flap or a graft. Other associated anomalies must be ruled out, and if need be, surgery for their repair should be performed simultaneously. So, a timely multidisciplinary teamwork is what is needed for repair of these patients. Our experience over the last 5 years consists of 54 cases, of which we had a male predominance with 31 males and 23 females. A sudden spurge of cases was seen in 2020, which correlated with immediate post-lockdown phase of pregnancies that was seen in 2020. These are some of the occult lesions at our center. As we can see here, the skin is intact, but the spinal cord is dysraphic over here. If we correlate this with the embryogenic phase of development, we realize that it is probably formed when the neural tube closure has occurred or in late stages of primary neurulation where the skin cover has already been developed. Myelomeningocele are other set of lesions which are repaired by us in our center. And this is how the defects look when when they are seen on the scans. And if we correlate them with embryology, we realize that probably these have occurred when the neural tube closure is in process and the skin cover is, that's why the skin cover is inadequate in these patients. Myelochesis are the more severe or the most severe variety that we see of these malformations. All of these were seen by us mostly during the post-COVID phase. As we can see here, the entire spinal elements, including the bony spinal cord as well as the overlying skin and the abdomen, everything is anomalous in this child. If we have to relate this again with embryogenesis, it is probably during early phases of neurulation where the neural plate is just about starting to form, or there is the closure which is just about to begin. So if you are correlating with embryogenesis, the pictures that we see on electron microscopy, we found it interesting that myelochesis was seen probably during the initial stages of the neural plate development. When the neural tube starting to fold, if a defect occurs here, we see myelomeningocele at different stages. And closed dysplapisms occur when once the neural tube closure has occurred. In our series, we had maximum brain anomalies associated in these patients, which could be as benign as corpus callosal agenesis, a polymicrogyria, or polygyria and anencephaly, followed by tethered cord in 23 patients. 18 patients had hydrocephalus and 14 had ACM or tonsillar herniation associated. Some pictures of associated anomalies in these patients. The first we have already discussed, a bifid spinous process and spinal lamina, associated scoliosis, hydrocephalus, and lower limb anomalies in these children. The treatment strategy was simple. Small lesions required primary skin closure. Larger defects needed a viviplasty or skin grafting. Lesions like this were easy to close and an en masse removal was possible. As far as prognosis of our 54 patients is concerned, in our 54 patients, we had 35 full-term deliveries and 19 preterm deliveries. 42 patients underwent surgery and 6 were transferred elsewhere or opted for treatment elsewhere. There were a total of 11 deaths in this series. Mostly in preterm, the death was related to low birth weight, and overall, the patients who had severe brain anomalies or anencephaly associated were more prone to death. So, in our opinion, early investigation and intervention of these defects, preferably in the first 72 hours, should be done. Small sized lesions can be closed primarily, whereas larger lesions require a flap or a graft repair. If there is associated hydrocephalus, shunt insertion should be considered during the surgery itself. Timely multidisciplinary approach with both medical and surgical team for preventing complications and improving neurological deficits should be taken. Thank you.
Shradha? And that was, as usual, a very good coverage. But as the time is not permitting, we'll have to move ahead. So I give it over to you to introduce the rest of the speakers and take forward the session.